Yeah, I would now invite Dr. Nobuyuki Shimokawa from Japan to talk on his technique of cervical pedicle screw fixation using O-arm.
My name is Nobuyuki Shimokawa from Japan. My title is Techniques of Cervical Pedicle Screw Insertion using O-arm. For the purpose of getting high accuracy of navigation system during spinal surgery, cervical pedicle is surrounded by vital structures such as VA, spinal cord, nerve root. Misplacement of pedicle screws occasionally causes catastrophic state of the patient. Anatomically, each direction of the pedicle is not same. C2 and C7 direction of the pedicle is not steep. This paper reported the great pull-out strength of the pedicle screws rather than lateral mass screws. Another paper reported the CPS was nearly 4 times greater than the mean pull-out strength of the lateral mass screws. We have performed more than 200 cases since 2002. In pathology, like this slide, materials and methods, we divided our cases into 6 stages. First one, freehand using C-arm. Second, preoperative CT-based navigation system. Third, O-arm. It's an intraoperative CT-based navigation system. Fourth, O-arm plus cannulated CPS. Fifth, full-time navigation system. Sixth, full-time navigation system plus miniscrews. First period, using fluoroscopy without navigation system. Second, we use the cell station. As you know, it's based on the preoperative CT scan. Occasionally, there was discrepancy between preoperative CT alignment obtained in supine positions and intraoperative alignment in prone positions. Third period, it's using O-arm. As you know, it's based on the intraoperative CT scans, and O-arm, it's a free registration. So it could shorten operative time and minimize the stress of registration for surgeon. However, there is another issue during operation. Pitfall. It's a movement of cervical spine, such as bending and rotatory movement during procedures. In the mid-cervical, because of the high inclination angle of the cervical pedicle, developed posterolateral muscles forces strongly the screwdriver handle towards the medial direction. Strong retraction produces a rotatory movement of the spine, which relates to the neurovascular injury. Even if with navigation system, this movement real-timely cannot reflect on the navigation monitor. To prevent the rotatory movement of the spine, we started use another skin incisions. Using syringes like this photo, after the making a pilot hole, insert the screws like this, like this. Can you notice the mistake? Screwing. This direction is correct hole of pedicle. But surgeon missed the direction of the screws. Until probing, we can check the procedures on the navigation monitor. But after that, we cannot check the procedures on the navigation monitor at that time. So We started the cannulated pedicle screws since 2013. Via the cannula, make the tapping and screwing. Using the navigation system, making the pilot hole. After that, insert the cannula into the pilot hole. Take the hole, tapping and screwing are performed via the cannula. But the another issue is the migration of the cannula. So we could using the full-time navigation system. Full-time means during all procedures, probing, tapping, screwing, we can check the procedures on the navigation monitor. It's a full-time navigation system. Using this device, other than making pilot hole, now tapping and screwing. It's a full-time navigation system. However, I noticed a new problem here. There is a slight discrepancy between the actual surgical field and the position on the monitor. Therefore, I decided to do a double check method, especially in cranio-cervical junctions. It's a O1 plus mini screw techniques, like this photograph. A reference frame, especially in cranio-cervical junction cases, we set the reference frame on the Mayfield tongue, like this. Set the mini screw, obtain the intraoperative CT using O1. You can see the mini screw. C2 level mini screw. Check the accuracy, like this. Next, C1. Good accuracy. After that, I obtain the confirmation with the good accuracy of the navigation system. So we could insert the C1 lateral muscle. Result: using the nose classifications, grade 2 and 3 is critical. This table demonstrates the accuracy of the pedicle screws at each stages. You can see the getting better of the pedicle screws step by step. Representative case. This case is a 40-year-old man. He has a chronic renal failure, so received the hemodialysis. At that time, he complained a slight gait disturbance. MRI shows multiple spinal cord compressions. So we performed the laminoplasty. But 2 years later, 4 years later, 8 years later, you can see the destruction of the cervical vertebra, especially in mid-cervical. 10 years later, kyphosis MRI showing The patient suffering from severe neck pain 10 years later. So you can see the retroodontotooth tumor. CT scan showing the destruction of the C1 and C2 of the right side. So we performed all the posterior fixations like this. Interoperatively, using the mini-screw and full-time navigation system, we inserted multi-anchors like this. After that, good bony fusion was obtained. The patient outcome is good. Retroodontotooth tumor gradually diminished. In discussion, this table showing the each outcome of pedicle screws using each techniques such as fluoroscopy, preoperative CT scan, and another navigation system, original template system, but not the complete. So it's a problem. In conclusion, when we use an intraoperative navigation system, it's most important to use precisely accurate navigation system. It's much important to share the pitfall of each procedure widely, and it's also necessary to use navigation more carefully. Thank you for your attention.
Thank you, Doctor, for this talk on cervical fixation by inserting cervical pedicle screws. And we can have a discussion. We can have a 2-minute discussion on this in case there are questions. Can I ask you that has it proven biomechanically superior to the conventional lateral mass fixations? It might sound a little elementary, but is it biomechanically superior to that, to the commonly done lateral mass fixation?
Yes, I think so. But the lateral mass is good. In ordinary cases, in good bony quality, lateral mass screw is very good. I prefer it. But in lower bone quality cases, such as hemodialysis cases or rheumatoid arthritis cases, I recommend using the pedicle screw rather than lateral mass screw, I think. Thank you.
We have time for one or two questions. Okay, thank you very much. And